So what we're going to, all I'm trying to do as a pracies is get you used to the idea that for many of you, you're going to be a big part in a trauma system. We're going to go through and finish tonight the various organs. Then we're going to look at a trauma system, and in that, what investigations will be done as a routine and what your role will be. And then finally, we're going to take a real patient with a real constellation of problems and go from woe to go with him. He doesn't mind me using him. It's someone I've used for the last 20 years, and he's one of our Gold Coast regulars, which should indicate to you, those of you who haven't worked here, means that when you see him, you'll know exactly what I mean. We might get cracking. Hey, is it 7? Yeah, let's get cracking.
Okay, see if I can get my screen to share and slides to turn.
So since I can see all three of you, Vinay, Hannah and Carolyn, that means I get to ask questions. Is that right? Is that fair? Oh, I see we've got other names maybe added on. All right. So we're up to the pelvis. Now, why is this important? No, we did tourniquet, so it should be next screen, mate, I think.
Yeah. Yeah,
that's it.
Yeah.
So for you to think about why we worry so much about the pelvis, you can see those bottom two photographs. The pelvis as a concept for you is a sphere. The volume in any sphere is 4/3 pi r cubed. Consequently, if we break the pelvic ring, and we must always do it in two places, you can't break a ring in one, that radius must increase. Since the vast amount of bleeding we see is venous, low pressure, we see that by increasing the potential volume, we increase the hidden volume of blood loss. So remember a couple of weeks ago, I said to you, when we worry about patients with trauma and shock, where have they bled from? We get a history, which is colloquially blood on the floor, and then there are 4 more sites. One is bilateral femurs, the second is the pelvis, the third is the abdomen, and the fourth is the thorax. This is the pelvis here. Breaking it means we potentially increase the volume of that sphere, and because it is low pressure bleeding, unless we can somehow tamponade that, and that is all a pelvic binder or splint does, we will bleed to death. So consequently, on our primary survey, when we come to the trauma system, we see chest and pelvis are the 2 and only 2 x-rays we care about. And they're there to tell us as much what is not there as is what is there. When I say not there, is there no fracture? Move on. We don't care about subtlety here. We're not asking of the pelvis, do I subtly think, no, it's either grossly bad or it is not. So next slide. The management of pelvic fractures is not controversial, but we need to walk it through a little bit. We need to decrease the radius, hence a pelvic binder. Now, those 3 of you who are there, feel where we're going to put our pelvic binder, and it is the greater trochanter of your femur. It is not high up, it is not your waist, it is not the bit that makes us all look attractive and looks terrific on our Instagram photos, but rather it is the greater trochanter. And everybody mistakes where we put the binder and puts it too high. think of putting it too high. If we do it and put it over the iliac crest, we will flare out the bottom. We will make the radius bigger, not smaller. We have good intention, but by putting it on wrongly, we make things worse. The binder goes around, in essence, the greater trochanter of the femurs, and we pull that together. There are various types of binder. In fact, you can use 2 bits of sheet, pull it together, and put it together with towel clips and Harrison Cripp forceps. That will work. Yes, Vinay, not dying of wondering. I see hand up already.
Sorry, I just want to ask you something. So we had a trauma case in Samoa not long ago, and it was a lower limb of the left hand. And one of the doctors put a tourniquet, and the blood started to like really gush out, and it's
So
just like.
Okay, so their mistake was the tourniquet was not applied above arterial pressure. If you apply the tourniquet above venous pressure but below arterial pressure, blood will come in, blood will not be able to get out. You've created a worse problem, haven't you?
Yeah, as soon as the tourniquet was taken off, the bleeding was stopped. So I was a bit confused. I thought
That's exactly the reason, Vinay. So, like all things we do in medicine, if we do it correctly, or we don't do it at all. Okay, you're either all in this game or you're not in at all. Doing it half-baked or wrongly actually makes things worse. So what you've seen with this patient with that tourniquet was to actually create blood in, no blood can get out, hence it goes everywhere, bar back to the heart. Now, if you had have applied the tourniquet above arterial pressure, so arterial pressure plus at least 20 or 30, no blood gets in, now you've got a successful tourniquet. Does that make sense?
Yeah, it does. Thanks.
With the pelvic binder, what we're trying to do is do nothing more. We will not stop arterial bleeding. We can't. What we're doing is decreasing venous bleeding, which is the vast majority of the bleeding we'll have. And we do it by making the radius smaller. And what we do is we apply a circumferential binder, in effect a tourniquet, for want of a better word. It's a terrible term, but it's a venous thing to decrease the potential volume in our pelvis, and hence our venous or low pressure bleeding will decrease, because we know its bleeding is about 40 millimeters of mercury. That'll just about stop venous bleeding. The next thing, however, is point number 4 there. That in itself is not enough. The next thing is to rule out abdominal bleeding. That's the key point. So it's not good enough to just put a binder on and go, duh, we will move on. You put the binder on and you still have to assume there is abdominal bleeding or abdominal catastrophe, because if that is present, all the binders in the world will not stop that. So very often we have the binder on and either a fast scan if you have access to ultrasound or a DPL. That is not looking at is there bleeding from the pelvis. We don't care. What we're after is there bleeding intra-abdominally, which mandates a trip to theatre. Do you appreciate the difference? So the mere fact we've put a binder on is in large terms a little bit like putting a splint on a femur. It is first aid. It is not in itself treating the other potential hidden sources, which are chest, for which we'll get a chest x-ray, and abdomen, for which we'll either image in a first world with a fast scan, and ask only one question of the fast scan: is there fluid? If the answer is yes, theatre. The answer is no, CT. Or in the third world, DPL. If the answer with DPL, and we'll do this when we come to the various pluses and minuses of the tests we have, theatre or not. The binder is nothing more than to stop the venous bleeding. It is first aid and can appropriately be put on at the scene. And it can be left for 12 to 24 hours. You might get pressure at 12 hours, but it can be left there, and there are numerous studies. Next slide.
Sorry, what's DPL?
Diagnostic peritoneal lavage. So basically, in the days before we could easily image, Carolyn, what we did was we made a nick below the umbilicus, and you did direct cut down into the peritoneum. You put a cannula into there, you put 10 mils a kilo of balanced salt solution, so about 500 mils of normal saline. You let it sit there for 10 minutes, and then you drained it out by dumping it on the floor, and you put a bit of newspaper there. If you could read the newspaper through the stuff that came back, you did not have 10 to the 5th cells, you did not need a laparotomy. If you couldn't, you did a laparotomy. That's actually, although a crude test, was well validated with the scientific number of 10 to the 5th cells. That's been replaced by ultrasound. To get a fast scan positive, you need about 500 mils. If you look at the shock tables I gave you, that's about category 1 shock. So it's about a bag of blood. So either one was about right if we looked at it. The other things for positive DPL was you got bits of stuff that came out that looked like feces, or you got fragments that came out that looked like we'd perforated something. Clearly they got a laparotomy as well for other reasons. But it's an old test. It's highly sensitive if the question you're asking is, do I need a laparotomy? It has no sensitivity at all for asking which organ is affected. But then neither two does a fast scan. A fast scan tells you have fluid. It doesn't tell you where the heck the fluid's from. And we must always, you raise a very good point. When we look at what we can do, we've always got to ask ourselves the pertinent question. The question in the resuscitation room is not what organ is bleeding. We don't care. The question is, have we got bleeding? Now, if we ask that appropriate question, both DPL and in the third world and ultrasound or fast scan in the first world gives us an exceptionally sensitive test. But it doesn't tell you whether it's spleen, liver, gut, God knows what. It doesn't tell you that. So you've asked a good question, Carolyn. We'll deal with it later when we come to the various pluses and minuses of what we can do for this problem. But that's what we've got. So here you see I've got some binders there. I've put in the third world binder, which is the bed sheet. But you can see you create exactly what the first world binder does, which is the proprietary thing. It's around the greater trochanter, and all you are trying to do is close the radius of a sphere. If you think of it that way, that's fine. You cannot make it worse. It can be left there for 12 hours. It can be used if you have urethral injury. It can be used if you have femoral injury, etc., etc., etc. There is almost no contraindication to it. Next slide.
Hannah's got her hand up, Greg.
Oh, Hannah, you're not going to die wondering. Okay.
No, not a question. I was just going to tell Professor McCabe that there's people in the waiting room wanting to come in. That's all.
All right. Well, how about you do that? Grab a quick cup of coffee and we'll let them in. Is that all right, Athel?
No, I think everyone's in that I can see in the waiting room.
Right. Still go and grab a quick cuppa because my little kettle's just boiled. Is that all right?
Right.
Yep. All right. See you in 2 ticks, guys.
Anyone else want to get a cuppa, refresh tea? Well done, Vanitha, with your FCE. See you on
Thank
Saturday.
you. Thank you.
Big day Saturday.
Yeah.
Got a few people on with you who's been there, done that. Got the
Yeah.
t-shirt.
Do we have OUM t-shirts? That'd
No,
be good, wouldn't it?
it
We
would be
don't.
good. Yeah, yeah.
No.
It would be.
Or
Would
at
be
the very
excellent.
least, an OUM mug. You know, we need a bit of merch. Isn't that what they call it?
We've got AUM water bottles that people got at the conference.
Yeah. Water bottles.
T-shirts would be good, wouldn't they?
Yeah, I think so.
Yeah.
Right, so coffee is done. Okay, here, for example, is what we would talk about as a reasonably generic approach to the fractured pelvis. So is there intraperitoneal blood? Yes, laparotomy, because whatever binder we put on is not going to fix that, is it? No, it depends on the logistics of your hospital. In mine, I have radiologists who have never met a vessel. They can't like to put a coil or bog or anything in. They're terrific. Otherwise, you're going to have to look at either external fixation or whatever, and your hospital will have an approach to that. So what you do in a tertiary hospital, which is mine, we would put internal, this patient would go to theatre, would get an X-fix put on, come back and get interventional radiology. They wouldn't do the interventional radiology with bone that's moving everywhere. They go to theatre with the binder, they'd get that coiled, then they'd get that fixed, then they'd get it coiled. If, however, you're in a third world environment, your general surgeon may well have to go in and pack this, and you leave a binder on if you don't have an X-fix. But they are variations of the same concept. What you're doing is controlling the radius for venous oozing and then looking to see if there's any arterial problem. If, however, you have intra-abdominal bleeding, no binder's going to help that. You leave the binder on, you go to theatre and you have your laparotomy. Then you can have a look and you see whether you pack or not. Happy with that as a concept, guys? All righty, next slide. Okay, cervical spine. Never has so much been written about so little that terrifies you so much, so we're going to try and make this very simple for you all. Next slide. First of all, how do you assess the patient's neurology with respect to the spinal cord? And it is the most distal level affected, and its motor and sensory may not be the same. In fact, may vary by 2 to 3 levels. The reason for that is if you remember back to your days of learning anatomy, the tracts are different, aren't they? The sensory tracts are dorsal, the motor tracts are ventral, the motor tracts cross at a different level from the sensory tracts, and unless you're highly lucky, most people don't have their high-speed injury necessarily horizontally. So they're going to get bruising up or down. So it's really important when you assess the patient, you do sensory and motor. Even more important for those of you who do it in ED, because we expect 20% of these to get worse before or if they get better. It is part of the apoptotic edema ischemia process. So we know what the best might be, which is often what you find. This may, of course, therefore be different in many levels from the bony level. So when you record the damage, it is at a neural level sensory, a neural level motor, and a bony level. Why does this matter? Well, if you have a partial spinal cord injury, and that means you have an intact any one of the modalities. So a sensory, that can be fine touch, that can be proprioception and or motor. Your chances of some recovery of a level or more are about 80%. If you have a complete injury, your chances of recovery to any level are less than 80% of what you've got now. So the fact that we can record one modality at a level distal to the one that seems to be obvious is crucial to the chances of rehabilitation and prospects. Now, don't fret. All of you in ED will do this crudely, and that's fine. When we have trauma teams, there are about 240 data points they will enter when they do these patients. This may take weeks to months to finally model out. But this is what they do, and this is why they do it. Next slide. A complete injury is no motor and no sensory of any modality. So it's not good enough to go, oh, can you feel my finger? No, in ED, you will do that, and that's crude. Over days to weeks, we will do each of those modalities. For the very reason I've talked about, rehabilitation matters as to whether they have any modality in any prospect. Okay? An incomplete injury is you've got some or any function. Next slide. Now, shock. Please understand the difference. Spinal shock is a local phenomenon. We've bruised the cord. It may or may not make some recovery. You may or may not get something back by way of increased modalities. And indeed, as I said, 20% of the time, it will get worse before it gets better. That is part of its inflammatory response. It is a local phenomenon. Neurogenic shock is the effect of cutting off your sympathetic chain. Vinay, you look frozen there. You're shuddering already. Is it that cold where you are, is it?
It has been really, really cold.
Where are you?
In Sydney.
Oh, okay. Here on the Gold Coast, it's not much better tonight, though. It's pretty freezing. We've had storms. So neurogenic shock is basically cutting your sympathetic chain. So in trauma, we do it by cutting your neck or your upper thoracic spine. But in reality, as we dealt with when we did the shock lecture, you will see this every time with analgesia, every time with spinal anesthetic, epidurals, and on it goes. It is the systemic effect of cutting your sympathetic chain. It is not the spinal cord bruising. The two terms are not interchangeable, and we must be careful to distinguish the two, right? The reason it's important is if we have a damaged spinal cord, we will do everything in our power to push up the mean arterial pressure, because we will assume that spinal cord in its contained compartment, i.e. the spinal canal, needs an appropriate blood flow, won't we? So what we will deal with for the spinal shock may be to push up mean arterial pressure, assuming the pressure around that cord is 20 millimeters of mercury. We add 60 to that, we will go for a MAP of 80. We're treating spinal shock here and pushing up our patient's blood pressure. Do you get that concept? So the two are very different. The spinal shock is the effect on the cord. The neurogenic shock is what we may have to deal with because of the cord, but also we may have to artificially push those numbers up because of the cord bruising in effect. Next slide. Now, the difficulties with our patient. Hannah, what spinal levels do you need to breathe?
Correct me if I'm wrong, but I think it's
I will.
C6 and above, just to get the thorax and your diaphragm.
I'm hoping not. Do you want to try more?
C4, 5, 6.
Yeah, 3, 4, and 5 is for the diaphragm to keep you alive.
3, 4, 5 keep me alive.
If you breathe that alone and you're fit and well, you'll get by. Most of our high spinals will, over time, not need to be ventilated, even if they're at 3, 4, because they can get strong enough with their accessory muscle, which is the 11th cranial nerve. But they do it by tricking and pulling up their whole chest as they get spasticity. Functionally, any cervical spine cord injury, you need to think this is going to fail. Now, how, Vinay, would we measure the failure?
By finding out their respiratory assessment.
It will be shallow, yeah. So what will go off first? Carbon dioxide, and I'll give you a hint, you need 7 to 8 mils per kilo to keep that normal. Or oxygen, I'll give you a hint, you only need 4 to 6 mils a kilo to keep that normal.
It'll be respiratory acidosis.
Terrific. So CO2 becomes your friend here in relation to their pattern of breathing. What you'll find is their rate may not go up a lot because they can't with their other injuries, but their CO2 will creep up long before their oxygen will diminish, because they need half the tidal volume, don't they, to be not hypoxic. So it's a bit silly to look at hypoxia. By the time they get hypoxic, you've missed the boat. More importantly, however, how many mils a kilo do you need to cough, Carolyn?
I don't know about coughing.
All right, I'll give you a hint. It's above 10, it's above 12, and it's below 15. So is there a hint here? About double what you need for your CO2.
Yeah.
Now, this is important because as our patient lies flat, you can see that their ability to cough, which means clear secretions, which means stop collapse, which means stop consolidation, insidiously creeps up on you. And you get the, oh my God, unexpectedly they failed. Well, no, it just meant we were too stupid to realise they couldn't cough. So one of the things we need to think about here is the inadequate ventilation is not necessarily going to be for you immediately in the emergency department. It might be the next day in the ward. And any trauma we add, any chest trauma we add, which makes the work of breathing higher, or the lungs stiffer, or the belly a bit more distended, requiring more work of breathing, is going to compromise us even quicker, isn't it? So the fact that we have our normal blood gas, our normal venous gas in the emergency department is terrific. That doesn't mean set and forget. It means this is as good as it's going to get here. It's downhill from here, and I have to look at the trend, and until I'm confident I can prove it otherwise, I am worried. Okay? So that's what the inadequate ventilation means. However, we have another lot of problems now. How do we assess normally that somebody has hurt themselves? We ask them, does it cause pain? So now we have problems. We cannot assess the abdomen. because it is anaesthetic, isn't it? We cannot assess the pelvis, nor can we assess for pressure areas, compartment syndromes, etc. in our limbs below our cord injury because they can't tell us. So we need to be very cognizant now that this patient not only is compromised with ventilation, but compromised with respect to circulation, if not now potentially with oozing, etc., because they can't tell us it hurts. And potentially their neurogenic shock is going to mean we're not going to get our tachycardia to tell us early. They're not going to be cool. They're not going to be oliguric because we've cut their sympathetic chain, haven't we? So the minute we have our spinal cord injury, we need to be very careful to say all bets are now off. Our examination is the best part of useless with respect to telling us about volume loss. We need to be very careful and look at imaging and or other methods to exclude hidden hemorrhage, because this patient can't tell us voluntarily, nor can they physiologically demonstrate to us the failings. Next slide. The treatment is fairly simple. Ensure adequate ventilation and oxygenation. Well, I would say that shouldn't be but you'd be amazed how often that is overlooked. If the person can spontaneously breathe and they do not need you to give them an artificial airway, non-invasive ventilation by way of high flow is a basic food group for these people. They need PEEP. So if you can give them 40 litres at 40% oxygen by nasal, that's terrific, because you've helped them cough, you've recruited their lungs. We maintain their blood pressure. That means we need a systolic blood pressure of more than 90. We will assume in this case, the same as a head injury, that our intra-spinal cord pressure is 20, because we have an enclosed space called the spinal canal, don't we? We will add 50 to 60 to that, which gives us the magic number of 90. 80 for a map, we'll go 90 for systolic, because we can't do maps at the roadside. That's what we want, and that's where that number comes from. Fairly simple. Now, as I said, the mean arterial pressure is 85 to 90 when we can put in either lines, in my case, or in your case, using non-invasive. That's the sort of map you're targeting. And you're going to target that with drugs. These people are noradrenaline-dependent life forms, or in the case of a ward setting, aramine, which is an alpha agonist, or phenylephrine, which you would be more commonly seen in the post-natal period for women who have had spinals. It's a pure alpha agonist. You need to squeeze their blood system. Now, early reduction, like any fracture, is good, but you need a skill set to do it. In the third world, that may require them to be flown out. That's fine. You can still maintain a mean arterial pressure of 80 to 90 by using aramine, phenylephrine, or noradrenaline. You don't need to put a central line in for low-dose NORAD. It's nice, but if you can't do it, it can run through a large peripheral vein. That'll be fine. All right, next. Management of hypotension. I consider neurogenic shock as my final endpoint. It is always bleeding until I prove otherwise. Really important. Neurogenic shock is what we expect to be there, but we always say that is what our expectation is. We need to prove it wrong for every other cause. Because hypotension by hypovolemia here will manifest late. Remember, we've got a patient who cannot vasoconstrict, who cannot have a tachycardia, who will not until somewhat later have oliguria. So we need to prove that is not there. Now, in the first world, these people get pan-scanned, and they get pan-scanned looking for exactly the bleeding we can't reliably examine for. In the third world, this would be the group you would consider a diagnostic peritoneal lavage or a fast scan as mandatory. You can do a chest X-ray, which will show you more than enough to say whether or not you have a large hemothorax there. You will be able to examine the femurs to look for occult blood loss hidden in those long bone fractures. You will get a history and an examination of obvious bleeding sources. But hypotension in these patients is always blood loss until you prove otherwise. Then it is neurogenic because you have excluded the otherwise. Crucial, because the best protection your cord has is stopping bleeding, isn't it? So that's what we have to do. Volume resuscitation pretty much is 10 to 20 mils a kilo and see what you get, the same as everything else. As to the vasopressors, there is no consensus. You go with what you've got. In your third world setting, either aramine or phenylephrine is easy because it's given peripherally. There is no ionotropic effect from either, but these patients don't need that. In my world, ignore adrenaline because that for us is what we use all the time. It doesn't matter. You need an alpha agonist, that'll do, okay? If you default to adrenaline, that's fine because that will also get you around a potential reflex bradycardia. It is overstated in real life. These people need an alpha agonist. By and large, that will do them. All right? But if you had adrenaline and you used it, that'd be fine. It doesn't matter. Next. As I said, no agents have been demonstrated to improve the motor recovery and neuroprotection. This is important because methylprednisolone is still used out there. It is based upon old studies. The NASCIS trials are now over 20 years old. If I had a partial spinal cord injury, I want methylpred, okay? Because potentially I will get maybe a level back. There is no statistical evidence to suggest in the whole population for spinal injuries as a whole, you will get a benefit. But in partial cord injuries, there is a body of case studies to say you may get a level improvement. You talk to your local spinal unit. Used, however, they are not without problem. It is a massive dose. The patients all become incredibly delirious. The dose we're talking about is 30 milligrams a kilogram load and 5.4 milligrams a kilogram an hour for days. They become unbelievably delirious. It is a massive dose. However, some spinal units regard it as beneficial for partial. As I said, if it was me, I would probably have it because I think one level is worth that. So you talk to whoever your referring unit is, okay? But there is no consensus overall whether it should be used or not. Next slide. Burns, something you're going to see a lot of. Next slide. I put this here for no other reason than to point out to you that burns are not trauma. The way I consider burns when I manage them, and I, for sheer luck, looked after all the Bali burns. I was the consultant on call when they came from Bali to Royal Brisbane. Burns, to me, are pancreatitis, but I can see the injury. Burns are bad sepsis. I can just see the cause of the inflammatory response. Burns are not just trauma. So you need to think of burns as being a huge inflammatory insult plus whatever else has caused the burn. So Carolyn, I'm going to pick on you. What do you have to think of? Somebody has been burned. 5 things that need to go through your mind when you pick that phone up.
You want to know what type of burn, if
No.
because I'm just
No.
thinking of smoke inhalation and stuff.
Okay, so that's the chemical thing. So I'll
Okay,
just
like if
raise
it's
to tease you. When we think of a burn, we need to think of the following. 1 is it's a blast injury. So did something explode and hit the patient? So we need to think of the inflammatory effect we'll get from the burn, plus, we'll get to the percentage burn shortly, plus the local trauma from something exploding and hitting them. Did they get thrown and hit something is the second. The next thing we then need to think about is the chemical effect, which is what you were talking about, Carolyn. And respiratory burns will be 24, 36 hours. The burns to the upper airway, which is face and mouth, is going to be early, usually peaked at about 16 hours. Okay? And then lastly, the chemicals that went with it. So when we have a burn history, we need to take into account not just the burn, but how the heck they got it.
Yeah.
And it's invariably an explosion until you think otherwise. And that means this is trauma, plus now the knock-on effect we'll be talking about with the burn. The trauma will go into the other areas we've already talked about. The knock-on effect is what we're going to be. Total body surface area we will come to. Vinay, next. How do you identify inhalation injury? So there is a picture I've prepared earlier for you, Hannah. What do you think? What worries you here?
Obviously, airway is the biggest thing that you want to worry. So change your voice suited.
No, just look at the picture for me, Hannah, and tell me what worries you on that picture alone.
Obviously, like I said, the airway injury, like an inflammation and edema.
Well, we can't see that there, Hannah. So you can see a lot of things that worry you. So now I want you to put on your glasses. This person's coming to ED with that and has been burned by petrol. What worries you looking just at that picture? Forget about the rest of what we might see opening the mouth. Just that picture.
I guess infection, risk of infection is one thing.
No. I'm talking about respiratory burn. Just that picture.
yes, he's not intubated.
Yet, but just that picture.
Swelling.
Come on, Vinay. What do you think
He's got
about his
facial burns.
Right. We got 1. He's got nose is red, isn't it? Eyebrows are missing, aren't they? Look at his forehead. This has been a flash burn to his skin there, hasn't it? Look at his beard. He singed his hairs. So already, before we've even looked in his mouth, Hannah and Vinay, this bloke worries me because look what's happened to his face. I don't need to look any further. Okay, this bloke's not ventilated yet, not intubated yet, and he's going to have a damn good reason for me not to now on just that picture. I don't need to look any further. I don't need to listen to his voice. I don't need all of that. That picture alone scares me because look at the amount of heat that's done that already to him. So I'm being a little bit pedantic now as we're moving through the lectures to try and get you to see that the picture tells you a lot before we have to then go to our lists. Already there, this man is going to have to, for me, have a compelling reason for me not to be putting and intubate and ventilate him now, right up front. Because there's any way, shape or form, can anyone here think that this is going to get better over the next day? Anybody? I've lost Carolyn there, so I assume she's still there. Yes, Carolyn, or have you disappeared?
No, I'm still here.
I can't see you on my little thing.
Oh, okay.
So
I can see people.
does
don't
anyone
see.
listening or looking here think that this will get better over the next 12 to 24 hours? So before we've even thought about the things that Hannah and Vino have quite rightly outlined, voice, etc., I'm worried now. Okay, I don't need to get much further. I'm worried now. Next slide. Now we can look at those things that you were talking about. Upper airway things are going to get worse over 12 hours. This is really important for you guys to know about. You never burn your lungs. You're dead before your lungs are burned. Okay, you burn your lungs from chemicals. It's what you inhale. It's the chemical you inhale, and it will be 16 to 24 hours. This is the so-called dry drownings or delayed drownings you might refer to. It's the salt water that they inhale, usually 3 to 4 mils a kilo. You don't drown on very much, and they get pulmonary edema at about a day. And it is a chemical effect. This group are the same. So this group will get their lung burns, which are chemical, about a day down the track. Not initially. They'll look good initially. The 12-hour ones are the airway ones, the mouth, the face. So we need to think and be very clear when we have our burned patient coming into you in the emergency department. Is this pure upper, what we see is what we get, which tends to be a flash effect. It tends not to be chemicals. It tends not to be an enclosed space. Or have we got the risk here that this was in a cabin, in a boat, in a camper, in a caravan? In which case we have to worry, is this going to get worse? And in which case then, that person, even if they look terrific when they come to see you, is not going anywhere near home because we expect they're going to get worse. And it's the story, the history from the ambulance will tell you that. When we looked in an analysis of deaths of burns in Queensland, the single worst prognostic indicator was living in a caravan. If you are over 60 and you're a caravan dweller, your prospect of surviving a burn was almost nil if you got to us. And it was a marker of the poor socioeconomic lifestyle they had, a marker of how frail they were because they couldn't get out, or a marker of the explosion because of the gas in an enclosed space and the chemicals.
You've got a hand up from Junaid. Greg?
Hand up, I can't see a hand. Yes, Junaid.
Sorry, that was to answer your previous questions. Sorry, I'll put my hand down.
Oh, all right. Okay. Yeah. So we need to, as part of our ample history, when we do it, part of that is where did the burn and was there an explosion? Because there are two very different time frames for us here. So when we look at our patient's picture there, let's look at that. He's got singeing of the hair. Yep. He's got eyebrows. Yep. His nose is gone. Yep. His forehead doesn't look good. Yep. I personally wouldn't be looking too close into his mouth at all. This man is going to be intubated unless I have a compelling reason not to. Because when do you think it's going to be easier, ladies and gentlemen, to secure his airway, now or in 12 hours' time?
Now,
So
because Yeah.
Absolutely. So if we don't want to be in an ugly place, part of the game of trauma is plan not to go there. Now, if none of that was there and his face looked terrific, but I had an enclosed space with that story, I know I've probably got 12 to 24 hours. He will reliably get worse and not catastrophically fall apart. And he will do it by worsening his ventilation. And Vinay told us before how we can assess that with our venous gases. We're going to look first at what, Vinay, as his ventilation gets worse. His carbon, what? Terrific. That's exactly right, Hannah. As he fails, we'll see his respiratory rate go up, or if they get weak, not, but the CO2 will reliably rise. And it will reliably rise before the oxygen fails, simply because you need less mils a kilo to ventilate as opposed to oxygenate. So we have time for the second group. They're not a difficult intubation because this is a lung problem caused by chemical, no different, in fact, from heart failure, which is water, pneumonia, which is white cells and pus. It is a different mode of lung failure, but it is lung failure. Okay, next slide. Any doubt we secure the airway? Can we go back to that one? That's one of my patients from Bali. Go, no, next slide out, Athel. That is that patient at 24 hours, and that is 28 centimetres at the lip. There is no more endotracheal tube. That's how far his face swells. We routinely wire those to the teeth. We do not tie them. This person came down from Bali via the bombing. We then get the Face Max guys to wire their teeth to the tube, because as that face swells, they will pull that tube out on a tie. So we actually wire that endotracheal tube to their teeth. Need to cuff the tube. What do you mean? Do we need to cuff the tube?
Sorry, I should have explained it properly. But as in, like with these patients, obviously there's going to be a lot of edema. It creates its own seal, doesn't it?
No. There is no such thing anymore, Hannah, as an uncuffed tube in anyone. Even in neonates now we use cuff tubes. So no, that's not a problem. You may need a smaller size tube. The reason you put it in early is you put them in early and leave them. But we hardwire these to teeth. In essence, provide skeletal fixation via the teeth to the endotracheal tube. So that is that patient 24 hours later, and that tube has got no more scope for swelling of the face. Look at him now up front. That doesn't look too bad, does it? But we have, if we now look at the light there, we see lips are gone. We see he's got the characteristic of his eyebrows singed, but under the eyebrows not, because the heat misses because of the eyebrow and the skeletal bossing there. The heat doesn't get the eyes. So you see a characteristic pattern. The forehead goes because it tends to be protruded. So that one we saw with our man before is a fairly classic picture. Cheeks gone, hair gone, forehead gone, eyes seemingly spared, eyebrows singed, and lips gone, because that's what we see. Next slide. Okay, ventilation, they will all have a high oxygen need because the burn will produce pulmonary edema if we get lung burns, but that is chemical, not heat. So a pure facial burn, as our man before, it's fine. He won't need a lot of oxygen at all. He has got an airway problem, but his lungs are okay if it's just heat. If, however, he's inhaled chemicals, we now have a chemical burn. This will last 7 to 10 days minimum, and it will be a high oxygen, high PEEP. Think of it as a pneumonia or heart failure environment, because that's what we have. Okay, next slide. Assessment and management, maintain organ perfusion. Now, this is where I say this is not trauma. Now, somebody wrote percentage burn. All the percentage burn is an indicator of how much inflammatory reaction you're going to have. And from that, we are going to look at how much resuscitation we have. This is pancreatitis 101, but you can see the burn. Pancreatitis is nothing more than a chemical burn of a pancreas, and we need vast amounts of fluid. Those of you who have seen it, this is the same thing, but the skin is what we're seeing. And we can use that skin, the amount of burn, to give us a guide of how much resuscitation we have. And lo and behold, my goodness me, we're going to use urine output as our endpoint. Heaven forbid. Now, this has been perhaps the best studied of all traumas in relation to adequacy of resuscitation. Nothing that has ever come up by any way of echo, CVP, arterial line, pick whatever else you like, has been better or as good as a urine output for burns patients. We still resuscitate them against an hourly urine output, which tells us a lot about the rest of our trauma modelling. Urine output remains as good, if not better, than anything else we can do. So this is what we target, adults and child. Next slide. How do you estimate burn size? You get out, you go to your online site, you get out a chart, and it will give you your percentages. Unless you do it for a living, you're not going to remember them, and neither should you. The easiest way at a scene, if you're in a third world thing, is the patient's hand is 1% of their body surface area. Get the patient's hand, run it over the burn, and that'll be accurate enough for you. Okay? So at the scene, that'll work. Their hand is about 1% of their body surface area. That'll work. Once you then get, and you can take photos, there you go. Next slide. Children, slightly different numbers. Again, just go to online or go to your charts. But again, a child's hand is 1% of their body surface area. All right, next slide. You will forever worry about, is it partial thickness, deep partial thickness? It doesn't matter to you at all. It's pretty easy. If it isn't sunburn, it's partial thickness or full thickness, and that'll do you for what you need. Okay, sunburn hurts, deep partial thickness hurts, and it's got blisters. Full thickness does hurt because of the surrounding tissue, but is in itself anaesthetic, and it looks like and will become like crackling on pork. There's no nice way to put it. And that, in a crude fashion, is as much as you need to know. You will always overestimate the extent of the burn, and that is because you will include around the burn the inflammatory reaction. That's fine. It doesn't matter. You start your resuscitation on the number you think, and you run that against your urine output. If you've got a urine output of 2 mils a kilo, I think we can probably reduce it because we've probably overestimated the burn. So what in effect you've got is your own quality control as you're waiting for a retrieval team or advice. And that's your urine output on an hourly basis. So the fact that you might be right or wrong by 10% is expected, and every burns unit expects it. So don't fret, okay? That's fine. You will always overestimate it. We all do as well. Next slide. Full thickness burn, see the difference here? See how it looks like eschar or pork crackling. This looks easy. At the time, it is somewhat more confronting because generally with that, you're going to have clothes burnt into it. You're going to have surrounding burn, which is not, and you're going to worry about is it, isn't it? Treat it as if it is partial thickness and run it against your urine output is a reasonable starting point. In fact, this does not need anywhere near the fluid volume because it's dead, but that doesn't matter for you initially. If you give 20 mils a kilo, put in a catheter, and you're getting 0.5 mil per kilo per hour, we're going to be delighted. So don't worry too much about it. Next slide. Baseline blood analysis and chest x-ray. The reason for the chest and pelvis is these patients are not going to be able to tell you, are they, that they hurt elsewhere or they've been exploded elsewhere, they've been thrown elsewhere. So we need to remove the hemorrhagic shock, don't we? Where are the hidden places? Fractured femur is probably obvious. Bleeding is obvious. The pelvis is not. The chest is not. The chest also, we have to think as time evolves of how the chest is going with chemical burns. So we need a time-0 chest x-ray, don't we? So the chest x-ray is mandatory. The pelvic x-ray goes with our primary series. The baseline blood analysis is for the same bloods you do for everything else. You do not need to do a carboxyhemoglobin level. Nobody dives these things. Nobody puts these patients into hyperbaric chambers. Nobody does cyanohemoglobin, and there's not much you can do about it anyway at the scene. We're doing the same baseline bloods we do for everybody else. Nothing different here. We will do a cross match because we are expecting hemorrhagic shock, a cross match because we are expecting there might be hemolysis with burns, a cross match because as our patients' burns evolve, we expect there will be marrow failure. But we are going to do the same bloods we do for everyone else. The nasogastric or orogastric tube's actually important for two reasons. These people are almost guaranteed to aspirate. Think of the chemicals they may have inhaled and ingested. Secondly, an ileus is going to be common with their hypovolemia. And thirdly, early feeding we want, and the best way of early feeding them is enteral. So a gastric tube, if you can get it in, is terrific. Any burn more than trivial, 10%, which basically is 10 hand breadths, gets an IDC. Okay? Anyone you want to put in hospital with burns that you're all worried about gets an IDC. Any male with burns because of the prostate problems they're going to have, and it's harder for them to pass urine semi-recumbent, gets an IDC. So if there's any doubt, you pop an IDC in. Wound care is relatively easy. Warm irrigation water and then cover it. And the easiest coverage for you is Glad Wrap. Okay, if we transfer patients from a country hospital, we tell them to go down to the hospital kitchen, get the Glad Wrap and wrap it, and then take photos before you do it. Does two things. It's incredibly good pain relieving because you've stopped the air on the cutaneous tissue. Secondly, you haven't covered the burn with dressings. Seal heat. Yes, it does. It seals heat in. It's very good for that. But the other one we then do is warm them with space blankets thereafter. Tetanus, these wounds are all tetanus prone. They are ischemic until we prove otherwise. So they all get an ADT as well. Next slide. Fluids.
Is,
The big trick, yep.
sorry, is there an indication for nitrazine nowadays?
For what?
For the silverzine?
No, we don't use it up front. We do in burns units. Your problem is we're going to have to wash it off when they get to us. So what you're doing is complicating the issue because we're going to have to wash it off. So it's easier for you to just wash it, wrap it and send it than use silverzine. Now, if you're in a long area, absolutely, but that's, you know, a long time. Now, in Queensland, we will transfer down from Cape York. Cape York to Royal Brisbane is 36 hours, 2 units, 2 aircraft to get from Cape York to Royal Brisbane, and we don't use silverzine for that trip. So now, obviously, from the South Pacific, it's even longer. Does this include facial burn for what? Silverzine, we never use silverzine on faces anyway.
No, I mean
Because-
like generally when you use for burns, because you're gonna do debridement, etc. You just basically use a glad drop and you send them upstairs. But is there a different protocol for facial burns, like using
Facial burns, all you're going to use is any aqueous dressing you like, it doesn't matter, and they will be sent down. If they're really bad facial burns, occasionally we actually do wrap them, but they're already ventilated anyway. But we're doing it not for the burn, we're doing it for heat loss. So particularly in children, we will often actually wrap their head and put them into bowel bags that the surgeons use for adult surgery, and do that for no other reason except it stops them losing heat from their head, because it's not 9% of their body area, but up to 18%, isn't it? So it's a vast heat loss. But we're doing it for heat loss. Sorry?
Would you use ointments?
No.
No, you wouldn't use. Okay.
We just use anything, glad wrap, anything you like. Ointments, no, we wash them off. It doesn't matter. Any aqueous cream will do that makes you feel better, but there's nothing as an advantage, Hannah. All right. Adequacy, basically all of the formulas, and there are many. There's a Red Cross, there's a Parklands, there's etc. They all work out somewhere between 2 to 4 mils per kilo per percent burn, half over the first 8, half over the next 16, and you start from the time of burns and add maintenance to it, and you run it against a urine output. There are any number of formulas, they all end up with that number. Okay, I tend as a preference to use the Parkland, which is 2 mils, and then add to that. But then I did this for a living for years in a burns ICU. Nobody is going to criticise you for 3, it doesn't matter. And if it is wet, warm and balanced, whether you use Hartmann's, normal saline or whatever, it doesn't matter. Okay? It doesn't matter. And it's always important to remember it's from the time of the burn, and you have to add maintenance to it. So you can see now why, if you are transferring these patients, if you're feeding them, there's 80 mils an hour of feed, that is their maintenance, and they're getting it as feed enterally. So we don't add our IV to their feeds, that is part of their maintenance, isn't it? Because you eat, you don't eat and take IV as well. So you can see how early nasogastric feeding for these people is terrific. We're giving them calories, we're protecting their gut, we've got to monitor that if they're tolerating the feeds, their splanchnic circulation is terrific, and we're not having to give a heap of it IV, and we're not getting protein or complex carbohydrate and fat, which we get with feeds. So that's why the nasogastric feeding early is terrific. All of this is at best an estimate. It's 0.5 ml to 1 ml per kilo per hour. If you get that, we're happy. All righty, next slide. Chemical burns are only different because you need to think of the delayed effect. So think of a chemical burn to a limb as exactly the same as the chemical burn to the lung. We said it's going to get worse, didn't we? 16 to 24 hours. So our chemical burn to the limb, we copiously wash it off, but we assume that the burn margin we see will get worse as that chemical effect that is now there, we've washed off the contamination, is still killing our tissue. Nothing you can do in ED, but we expect this will get worse. All righty, next slide. Management of electrical burns. Electrical burns are nothing more than you can't see it and the muscle is fried if you think about it. So an electrical burn may look disgustingly normal in the skin. It is a compartment syndrome to muscle damage below. So the key here with electrical burns is examination, and then re-examination, and then re-examination, because as we resuscitate them, in the same way we saw our compartment syndromes get worse with our crush syndrome, we have created here a crush syndrome ourselves by the muscle dying and then having a compartment syndrome with the skin that hasn't yet died, but the muscle is swelling. Okay, so look at this patient. No skin burn at all. There is a limb. That is all muscle on view. This is an electrical burn. Less so do we see it with lightning. Lightning tends to either kill you at the scene or you get a flashover effect. But we will see this with domestic electricity and the higher tension stuff in the industrial areas. Okay, next. Who do you transfer? The answer is anyone you're worried about, you ring about. But rule of thumb is more than 10% body surface area or a burn affecting anything in a delicate spot. And lastly, or in a delicate patient. So if someone has comorbidities, you get rid of them early. So 10% plus anything gets you a Guernsey out. Less than 10% gets you a phone call and maybe a Guernsey out, depending on where it is the easy way to think about that. Next. Significant electrical burns, they will get worse. Get rid of them. Lightning burns, yes, because they tend to be a defined little discrete group that get long-term effects. So 12 months down the track, they will have cataract problems, etc. So they need to go to special units. Chemical burns, for the reason we said, what you see is not what you've got. Inhalation injury, for the same reason, what you see is not what you've got. So you get rid of them early. Pre-existing injuries, if someone is diabetic with already poor microvascular circulation, let's add burns to this. It's not going to go well. So it's better to get rid of them early, isn't it? The same if they've got comorbidities with heart and lungs. All right, now the next bit is important. The burn may be a stopgap. So your burn you see may be a stepping stone. So if someone has burns plus a compound femur, we need to be splinting the femur. We need to be fixing or putting a binder on the pelvis. We need the laparotomy for the bleeding, don't we? So the burns, you may have to look after for a day or so because you've gone ED theatre laparotomy, ICU or whatever pending, transfer to a burns unit. So the burn is not in itself just the sole problem often. I often think of it as as I said, this to me is always pancreatitis on top of trauma. The patient has severe trauma. I'm now seeing the inflammatory process on top, and that has to be dealt with as well, but not instead of. And if you think of burns in that fashion, you then aren't going to miss, because of the spectacular nature of the burn, the underlying critical problems. They still have a head injury. They still have the need for laparotomy with hypovolemia. You need to always think about that. All right, next one. Trauma boutique groups, children, elderly and pregnancy. So let's deal with them each. And you can help me here. Next one. What aspects of childhood anatomy do I need to consider? I've only got Hannah, Vinay and Carolyn on my little screen. Wait a minute, I will flip. Oh, gee, I've got a whole heap of people. Galaxy, I can't see your photo, but there you go. Can you help me? What aspects of childhood anatomy do I need to consider as a group? Let's do this as a group, guys.
Can you hear me?
Yes, I can.
Okay. I'm just going to ask if you could repeat the question, please.
Well, we're talking about Trauma in
Bron-
children.
children. Yeah.
Special things in children would I have to consider with trauma?
You need to go your ABCD, E like normal.
I agree with we're going to do normal, and I think you've hit the nail on the head. Our priorities will be exactly the same, but let's now look at A, for instance, and think in children, what particular aspects of A may cause us some angst? And if you don't know VAFA, I think that's terrific.
They've got a shorter, one of the Broncos is shorter. I can't remember which now.
Yeah, look, to be honest, mate, that isn't going to matter. You're quite right. But that's not until the age of 2. So children are equal opportunity aspirators. Your bronchus has got an equal separation. And as you grow and your heart gets bigger, the left one pushes out a little bit. So adults tend to inhale down the right main, but kids until about the age of 2 to 3 are equal opportunity aspirators. So not quite, but no. But what else do they have? So let's start at their head.
Is it something to do with the fact they have brown fat?
No. So let's
Basically,
start with their airway. Let's just start with airway, guys. How about that one?
They have a shorter neck, and basically, when you're considering airway, it's about securing the airway easier. They have a bigger head, so maneuvering I lost you. I think everyone's frozen on my side.
I think, look, you've raised a good point. They have a
I think
bigger
the
head.
shape of the airway. The shape of the airway
No, not really. So if we think
is
about it,
different in children.
so first of all, let's start with bag valve and mask. They've got a small mid-face. So in effect, you've got a different mask, haven't you? Has everyone seen pediatric masks? For those of you who don't have access in the third world, what we do is we take an adult mask and reverse it. So you put the sharp bit over the chin of the child as opposed to the rounder bit. You know, and the adult mask is triangular. If you're going to bag valve and mask and you have the sharp bit over the nose, in a child, we reverse that if you use an adult mask because the chin tends to be rounder and the nose, the chin tends to be sharper. So you put the sharp bit over the chin and the round bit over the nose. The second thing they do is their head is bigger, so you don't need a pillow to put them in a sniffing air position. The third thing, however, is they get teeth, don't they? And teeth are loose. So we need to always think about that, and their tongues tend to be relatively bigger. Having said that, they've got a pretty good cardiovascular supply, so they'll breathe. Let's move down a little bit, though. What about their ribs? Your ribs tend to be rounded. What are the child's ribs? They tend to be very flat, so they have a very inefficient breathing system, which is why children's respiratory rates are higher, and when they get exhausted, they become hypoxic very quickly. So children have a very inefficient way of breathing because they have a chest that tends to be almost like, you know, a sort of cylinder. And what about their tummies? They tend to have a pretty big tummy because it's full of liver and spleen, isn't it? So they all have pot guts, so that they don't have a great respiratory reserve. So we need to think about that, don't we, with children? So airway and breathing in children tends to be a bit of a problem with that. Is there any other anatomy we need to worry about rather than brown fat? So what other bits of anatomy are there?
The actual size of the airway from the nose to the pharynx is very thin.
Yeah, look, you're right. But again, we have a look down. It's not a big thing, and we can grade. So how would you size a nasopharyngeal tube then? Because that's what you're talking about, or a Guedel airway. How might we size those? You've raised a good point.
from the tip of the mouth to the tragus of the ear?
Terrific. Well done. Well done indeed. So although you said quite rightly the sizes are different, we can use the patient as their own standard, and we can be pretty accurate. As for the tube sizes, Aegon 4+4 is the old thing. There are Brentzlow tapes now that pretty much are ubiquitous throughout the whole world. Even UNESCO use them, which give you an idea and basically gives you age, weight, height, and bang, there you've got, this is what you're going to use. And that's almost ubiquitous through the world. As for putting the tube in, pretty much the minute it goes below the cords, that's fine if you have to do it. So technically, although we get a little bit excited about it, by and large, it's technically not a difficult thing to put a tube in. However, we do have problems with access for circulation. So what things might we use in circulation?
Can we use IOs?
Terrific, well done. So we know the Australian Resuscitation Council says you get 2 goes and then it's an IO, is their standard for resuscitating children. And I can only talk about Queensland because we put them in, every crash trolley in Queensland in the bottom drawer has 2 EZ-IO kits. And that is put there for specifically that reason. And it is in every hospital in Queensland Health. And they're in the bottom drawer, EZ-IOs. And they're put there for the children. You can do them in adults as well, but that's what they're there for. So venous access can be a problem. The EZ-IO has made that very, very simple for you guys. Instead of a cut down, for those of you who are technically minded, it is as good as a central line. There are studies done with radioisotope scanning, doing CPR on cadavers. With an EZ-IO placed, the radioisotope scan is in the central circulation within 30 seconds in a cadaver with CPR. It is a central line. You can give everything through it. You can't, the one thing I would advise you not to do is use sodium bicarbonate and follow it with calcium because you get limestone crystals. But apart from that, you can give everything, every drug, and you can give volume through it if you use a pump. And the pump I use is a pump off an IV giving set, and I use a wardsman or a resident to basically squeeze it. So it is highly usable, highly accurate, highly available, and is easy to do. So have all of you done it or been exposed to one?
Yes.
Yeah.
Yes.
Yeah, in some training, yeah.
Absolutely. And it is no harder in real life than training. The most common times we do it actually are in adults now. And they're in adults either at accident scenes or in hospitals where you've got adults who are IV drug users and they're fitting or whatever, and they're easy to put in. So they are remarkably easy in real life, no harder, indeed, I would argue easier than the mannequin you've trained on. And you can use everything. So that they're good. All right, next slide, Athel. So longer tongue, narrower draw, we've done all of that, and we talked about turning the mask for your bag valve and mask upside down. If you're using an adult mask, it works very well. Next slide. We talked about the occiput. So we put the pillow instead of under the head, which is what we do for an adult for sniffing air, we put it under the neck, don't we? Next. Larger head. So we're going to proportionally lose heat here, we've talked about, but our skeleton is cartilaginous. So we're not going to see the same fractures we see in adults. We're going to see bent bones. But importantly too, if we do see bad fractures, we have to consider often in children non-accidental abuse, don't we? Next slide. The cervical spine, cut to the chase. If we're at all worried, we scan them. it is almost impossible unless you do this for a living to interpret a child's spine, and nobody does lateral spine x-rays anymore at all looking for bony injuries. What is Sciora? Does anybody know? Vafa. Desalam, you can help if you want. Stunned silence.
Honestly,
Sorry?
I don't recall what it is.
No,
I've
I'm
come
not
across
expecting.
it, but
Okay, so if we think about children and look at that x-ray, do you think you're going to see bony abnormality in a largely cartilaginous spine? So what we have to remember in children is we can get spinal cord injury without radiological abnormality, and that's the anagram for it, Sciora. So we need to always be wary in our child who may have a cervical spine injury. The mere fact that we can't see it on an x-ray or even on a CT does not mean we don't have a cord injury. And it's something that we just need to bear in mind. Now, this becomes important because look at that spine and look at the big head on it. Can you see in a car accident or a fall from a height, the angle of motion that would pull on that spine? So you can see how you could get a cord injury but not see much on that spine because we have a very big, very heavy thing connected to the torso with a very fragile yet undeveloped thread of tissue, haven't we? So we need to always think about that. Next one. The chest, classically, that picture. So what does that picture show you? I don't know, Junaid, connecting to audio. Does that mean you don't? If not,
yes, yeah.
What does that x-ray show you? What can you see on that x-ray, mate? It's not subtle. So just tell me the big things.
Oh God, it could be complete. Is that like a hemopneumothorax or I'm making up?
Let's go back a little bit here. Okay, so chest x-rays, and we'll do a whole lecture on this. When you look at a chest x-ray, it's either too black or too white. And if it's too black, then we look at things that are pushed away from it. If it's too white, we look at things that are pushed away from it or pulled if it's collapsed. So let's look at the two sides there. The left side, is it too black or too white? And I'll give you a hint. There are no too black. So if it's too black, now, if it's too black, that there's only one thing that can do that. It's got to be air. So the next question we ask with air is, are we pushing away from it, or is it just the same volume and the lung has just collapsed? So let's see. Are we pushing away? Well, look at the diaphragm there. Yes, it is. Vinay, well done. It is a tension pneumothorax, but it's a tension pneumothorax because we are pushing down the diaphragm on the left, aren't we? And pushing away the heart and mediastinum to the right side of the chest, aren't we? But we've done this in a child without any fractured ribs at all, because the ribs themselves are largely cartilaginous. They bend, they bend, they bend, but they don't break. So when we have pediatric injuries, we have to always think the injury isn't going to be the bony skeleton like it is in old people like me, because that's the most fragile. It's going to be the organ underneath, isn't it? Because the bony skeleton or cartilaginous skeleton can bend and be pliable with things. So this is a nice message to us that this is what we need to look at. By the way, Vafa, what sort of shock would we get here? Hypovolemic, obstructive, cardiogenic? What sort of shock do you think? Well done, Hannah. It's obstructed because what happens is as we push our mediastinum, we stop the blood flow coming in from the inferior vena cava, don't we? So that's what we do by moving the mediastinum. Okay, next slide. The abdomen. So again, what we have to think about here is we're not going to see much bruising. We have to think about below and underneath the abdominal wall. We also have to think here that things are often inside the abdomen, whereas in adults they're not. So in an adult, we know when you breathe out that your liver and spleen, the diaphragm gets all the way up to the nipple line. So largely in adults, it's pretty hard with blunt trauma to knock off the liver. We can do it, but it's a high-speed injury. The spleen less so because it tends to be below the rib cage. In children, all bets are off here because both are under the rib cage. Both are in the abdomen, as is the bladder. So we need to think here of a slightly different pattern of injury. We more commonly see solid organ injury and or bladder than we do bowel injury, which is an adult type of injury, because we tuck the others away. Next slide. Okay, physiology. So how will the physiological damage differences impact the my management? The answer is next slide. They really won't. You're going to still do A, B, C, D, E, but you're going to have to remember there are slightly different numbers. Absolute, because you've got a smaller volume, haven't you, of person. The A, B, C, D, E's will still be correct, but the normals will be slightly different numbers. A pediatric respiratory rate will normally be higher than yours or mine because they have a less robust, developed system to breathe. They're not designed to ventilate well because they have big bellies and they have a poorly developed as yet rib cage. So we need to remember that. Next slide. Oops, back. One back, Athel. So here are some guides to what are the new normals. That does not mean you need to know them. This will be on your various Bredeslow tapes or whatever you have by UNESCO. Every ED you will work in will have this up on the wall because nobody remembers, unless you do just pediatrics, the expected new normals. But we will see the same when we come to our pregnant lady. We will have new normals. It is part of the physiological evolution with age. That's fine. Our principles will be the same. We just go, oh, yes, it's a 6-month-old and. So we need to just this. You don't need to know this at all. This will be up on your walls. Next slide. This, however, is something you need to imprint in your mind. Because you have an unbelievably good pump that is almost brand new in children, until they are just about dead with 40-ish% of blood loss, they will not become unconscious and die. You need about 30% before you get much change. So the mere fact your numbers look good is not sufficient to say all is well. It's good because the underlying pump system is coping very well. However, we go back a slide, Athel. Our respiratory rate remains our friend, because the thing that doesn't work well in children is their ability to ventilate well. Hence, respiratory rate becomes your friend. And this has been backed up in all of the Met-Call data in paediatrics as well. The single best guide to is the child sick or not is the respiratory rate. So that is your best friend here. Two slides forward, mate. Okay, fluid management, wet, warm and balanced will do. It doesn't matter what you use. Normal saline, Hartmann's, it doesn't matter. It just should not be lolly water. So it's not 3 1/3, it's not 4 1/5. You need to now make a distinction for the rest of your lives, ladies and gentlemen, between, on the one hand, resuscitation fluid, which is balanced salt solution, and what is used for maintenance fluid with some carbohydrate for children. The two are fundamentally different. And the way I think about them in my mind when I write up fluids is, one is resuscitation, and I do that calculation. The other is for them maintenance, and I do that calculation. The two never, ever, ever meet. Lastly, blood, 2 boluses equal blood. Pretty easy concept. So adults 1 to 2 equals blood, children 2 equals blood, pretty common. And early use of mass resuscitation. We talked in adults about using a massive transfusion protocol. In children, 10 to 20 mils, bang, second one, you're going to be using platelets and you're going to be using product. The volume will be less than you used in an adult, but proportionally it's no different. It's 10 to 20 mils a kilo, repeat, and then bang. And it's for the same reason. Giving old, cold, red stuff does not mean you're going to clot at all. Next slide. Now, permissive hypotension. Yes. So we do this in children, but we do it in tertiary centres where you can pick up the pieces and without head injuries. So this is the area you would be seeking advice, and it is a well-trodden track in children with solid organ injuries, but like adults, all bets are off with a head injury. Okay? We do it and we run it against urine output. Thereafter, maintenance fluid, I've given you the 4-2-1 rule. It's no different from what we do. And that's just maintenance. Maintenance can be any fluid you like with a bit of carbohydrate. Resuscitation is balanced salt solution. If somebody talks to you about permissive hypotension in the context of paediatric trauma, a very well-trodden track, but only without head injuries. In the context of adults, a very well-trodden track, but only without head injuries, and only really proven in adults in penetrating trauma, but it has started to move into the solid organ thing where we can prove nothing else is wrong. But certainly in children, you will see this used, and for good reason. Okay? Next slide. Thermoregulation. Children are designed to lose heat. Okay, we found this with burns. Their heads are big. Shivering is bad. Core temperature under 35.5. You won't clot, I won't clot, and the child won't clot. pH under 7.2, your heart doesn't work. Core temperature under 35.5, your heart doesn't work. It's easier not to lose heat than to have to warm them up. So once we've assessed them, you wrap them up. You keep the heat there. Now, have all of you seen the neonatal cribs for resuscitation that have overhead heat lamps?
Yes.
Children, if you can't do that, we wrap them up. Space blanket, the whole deal. Warm blankets, and that's the reason we do it, is they lose heat. Vino looks like she's just about dying of hypothermia with her heart as I'm looking now. Next slide. Look at that. Who told me the principles would be the same? Hannah, I think it was, and you're quite right. The priorities are the same. The normal numbers are a bit different. There are some quirks with children, but once we get over the emotion, the principles are the same. Next slide. Airway obstructs easily. We've dealt with that. You're going to sit them up as soon as you can. Tension pneumothorax, the reason we talk about that is we think about the organs underneath here. We don't think about the body wall. Vascular access, 1-800-EASY-IO will get you out of a heck of a lot of problems. It has revolutionised this area that used to be so scary. The paediatric GCS score, for goodness sake, you're not going to know it. It is not that well validated anyway. It is age and development congruent. By and large, you're going to get a guide, and that's what you're going to get. Avoid heat loss is mandatory. The reason it's there for E is it goes A, B, C, D, E, but as somebody who has to deal with cold patients all the time, it makes C an enormous problem because of 1, the heart, 2, the acidosis, and 3, they don't clot. It is a nightmare. So E is really important. Okay, next slide. Geriatrics. So, next slide. Look at the decline with function with age. And the reason we'll go through all of this is not that it will change our A, B, C, D, E, but I want you to start to think about how when we get our geriatric trauma, we need to think a little bit laterally about the effect with their underlying function. And I'm going to make you, and I'm going to give you a conundrum. All of you, I want to come up, can you think about the mortality in somebody over the age of 60 who falls over and breaks 1 rib? And I want you to think of a 30-day mortality for me. And now we'll go through this. With age, decrease in brain mass, what will the effect of that be? Well, 1, there's less resilience. Over the age of 62, you can make a compelling reason to not resuscitate statistically a severe head injury. It's not that we don't do it, but statistically that will happen. Yes, delirium. We know that if you have a delirium for more than a week in a hospital, your 1-year mortality is 60%. But also with your cerebral atrophy, your risk of a subdural hemorrhage, remember, is higher because you have a small brain inside the same size box. So not only have we got less resilience, we've got a higher propensity to fall over and tear that venous system. Now, NOACs, antiplatelets and or warfarin are now basic food groups for the elderly with their cardiovascular problems, aren't they? So we've got now the double whammy. A, they're more likely to fall because their brain and balance is worse. B, they've got cerebral atrophy. And C, when they get it, they're more likely to bleed. Their perception goes, yes, so they're less likely to protect themselves. Respiratory vital capacity, yes. So has anyone got an idea of what the 30-day mortality of breaking 1 rib in someone over the age of 60 is? Carolyn, give me a number.
I'm not sure what you mean in terms of a number.
1 in 5 will be dead in 30 days if you break 1 rib over the age of 60. And for every rib you do on top of that, you will add 20% to that number.
I see what you're getting at. Yeah,
there
right.
is no such thing in the elderly as a non-significant chest injury. 1 rib is 20% 30-day mortality in all comers in Australia. So that is how, that's what we're talking about in this group. It's not the rib fracture. It is the fact of the frailty underlying this particular problem. Now, with that, we have people who will have intercurrent disease, won't we? Respiratory disease, etc. So now we're going to add our chronic airways disease onto this, and you can see why their respiratory function is appalling. So in these patients, any rib fracture, any chest trauma is not minor. It is potentially massive. One of the hospitals I work at, Robina, we get rung about every rib fracture that comes into Robina Hospital. Major trauma goes up the road. They all get known to ICU or come to ICU for nothing more than a PCA that night, and they will all get a block unless there's a compelling reason the next day. The reason is by doing that, they don't come back to me. They'll get 5 to 7 days out of a block and they get flogged with physiotherapy. That's the extent we take in a trauma hospital where I work. Every rib fracture goes either to trauma, if it goes to the tertiary hospital because it's high speed, or to ICU to arrange their anaesthetic block day 1, the next day, to stop that mortality. It's really important. So that's the sort of frailty we're dealing with in this group. Renal function. So what should happen to your creatinine with age, Hannah?
Your creatinine increases because your renal function.
It doesn't. It should stay the same because your muscle mass goes down. So it's really interesting. If you have a high normal creatinine in an elderly person, their kidneys are terrible because their muscle mass is less. So we all think it should go up, and you're quite right. Your kidney function decreases, absolutely. But your muscle mass goes down as well, so your creatinine shouldn't change. So a high normal creatinine in the elderly means their kidneys are awful. Really interesting. Okay, total body, we don't have to worry about that. Coming down, sense, smell, etc. Now, cardiac issues. So what did we say happens with shock when we did our talk? What happens? Do we fill our heart in systole or diastole? I'll flick through to the group that are hidden here. Galaxy can help me here. Galaxy, do you fill your heart in systole or diastole, darling?
In diastole.
Terrific. I want you to be more precise now, Galaxy. Do you do it early or late in diastole? Is it early and passive or late and active with your atria? You're a young, fit girl, so which one do you reckon it would dominate?
Early and active.
Early and passive. Well done. So now when you get stressed, a bit like probably now because I've asked you a question and you've got tachycardia, as your diastolic time goes down because systole doesn't change no matter what your heart rate is, you rely more and more and more on your atria to fill your ventricle. What happens to the elderly with their cardiac things? What rhythm is almost ubiquitous in the elderly, ladies and gentlemen? Atrial what?
Fibrillation.
So what we have as a group who, as part of their aging phenomenon, are already losing their atrial kick. Can you see why any volume loss in the elderly is in fact worse for them proportionally than what we think in our basic table? Because they don't have the compensation necessarily, do they, of an atrial kick with a sinus rhythm, do they? So early volume resuscitation is crucial in this group. They don't have the reserve. Atrial fibrillation for them is a marker of frailty and a marker of early death because there is no reserve here. Again, an important concept to look at. And with that, when you are looking after them in the ward, so they look, yep, they look exactly right. Now, in the ward, when you're looking after them, what 2 electrolytes did I say are therefore their preload electrolytes? Does everyone remember that talk? One starts with P and ends with potassium, Carolyn, and the other one that goes with it starts with M and ends with what, Hannah?
Magnesium.
Magnesium. Well done. Okay, they're the two electrolytes that matter in this group when you look after them, because it's better either not to get atrial fibrillation, or if they've got it, for it to be slow than it is to have to treat the damn thing because their electrolytes are leached out, because that's what happens with their other drugs and their kidneys, which aren't as good. So this is why it's important for that day-to-day tidying up of your patient's physiology. It's not mundane, it's crucial. And that's why trauma teams work. They don't do anything for the elderly except basically do what I'm telling you, these simple things. Okay, now the rest of it goes down. They lose, by the way, they lose heat tremendously and they don't shiver well. Next slide, Athel. Priorities are the same, but we've got to do it earlier because we have less reserve. You're going to need 12 to 15 milligrams a kilogram to cough. You're tough, you're young. Let's fracture a rib in someone over 60. Do you think they're going to cough? Let's add a lifetime of cigarettes to that. Now we're going to have some COAD emphysema, some secretions on a good day, a bit of marginal heart failure, and now they can't cough. Can you see how this is going to go badly very quickly? So we need to think early, either not, and limiting treatment is fine, but we make that decision early, or if we are not going to do that, they need adequate early intervention. That doesn't necessarily mean intubation. That means high flow nasal. That means physiotherapy. That means proper analgesia. So we can get them up, get them mobile, get them moving. Okay? To put this in perspective, neck of femur fractures, what is their mortality if we don't operate on them within 36 hours? Does anyone know? You can have a guess, Vafa. Really high, 80%, you're not even close. 96% will be dead if we don't operate them on 36 hours. It's not because we're good at operating on hips. What we're good at doing is getting them up and getting them mobile so they don't die of their pneumonia, heart failure, etc. 96% will be dead within a month if we don't operate on them within 36 hours. Okay? Now, if we do operate on them within 36 hours, it's got about a 20 to 60% 1 year mortality, depending on their comorbidities. It's got nothing to do with how good the orthopods are. I chide them, I can tease them. But one of the things that's very good is getting these patients up, getting them moving. And for that, they need a hip. Part of your job to get them up and get them mobile with that is no AF, high flow nasal, a good cough. Do you think it's easier for the elderly to cough lying down or sitting up and moving? Duh. And they don't get a delirium either because we can get them outside. And I said to you before, someone with a delirium for a week in a hospital, 6 in 10 are dead in a year. Next slide. There are some unique neurologic problems. If you look at that scan, it's an MRI, you can see that there is a loss of white signal density, which is water, down the cord at about 3, 4, 5, 6. Can you all see that on the lateral? Okay, it's called a central cord syndrome. It is invariably in middle-aged alcoholic males because they're the ones who tend to fall down steps drunk. And what they do is basically they have over time gotten a stenosis there because they've got arthritis of their vertebral bodies at the back of them. As they bend their neck, as they fall, they basically get a contusion to the cord and get a thrombosis, the anterior spinal artery. Arms more than legs are affected. Bladder and bowel are really affected. And it has a really, really bad outcome because these individuals are already tend to be marginalised in society and now are worse because of arms and legs. The treatment is for any other spinal cord injury. The X-ray will look disarmingly normal. It will be reported as osteophytes, yada, yada. Sure, you won't see a fracture. But when you examine them, it's arms more than legs and bladder and bowel, because that's the way the motor fibres are as they come down the spinal cord at that level. So you need to look at that. Early catheter is vital in these people because once the bladder's distended and stays there, they get an atonic bladder potentially for life. So we need to think about it. Next slide. Unique problems. So most frequent. So musculoskeletal neck of femur we talk about, and that's caused the fragility. Susceptible to certain fractures. Yes, neck of femurs. Yes to ribs. Okay. Osteoporosis. Yes, but overstated. They're going to get the same pattern of fractures as their cohorts will. The deformities, however, do complicate your problems because is it new, is it old, is it causing problems or not? So you need to have a wide view. And the last one with this is the subdural. Remember, we have a little brain inside a box that's got a lot of sharp edges. So that's the one that's often overlooked, is the chronic or acute on chronic subdural. In this group, it is not going to manifest early. The coma score may be quite normal today. 3 days later, it's off a bit. It doesn't mean you missed anything. This evolved because it's got a bigger space to bleed into as a venous bleed, hasn't it? So we need to think when you're looking after them in the ward with their neck of femur, they're not quite right day 3. Maybe it's not that they're delirious because of their drug withdrawal. We have to think, is this because they've got a subdural that is evolving with time because it's a acute on chronic problem? So these are the sort of things we need to think about. Their trauma may manifest late or in strange ways because their physiology is a little changed and there's more space to let it evolve. Next slide. All right, pregnancy, always asked. Okay, at Gold Coast, it is so common, we joke because we have had males come up with negative beta-HCGs with trauma. Okay, it just runs through the system and we laugh at ED, but we have males with a negative beta-HCG. So my view is every female gets a beta-HCG. End of story, I just do them because that's easy. So we always ask or test. Since they can't tell me, I test. Now, there is a picture there. What problems may we have in this picture with our resuscitation, VAFA? And we'll run through pregnancy and finish on pregnancy, VAFA. So what problems with pregnant lady there?
I guess one of the biggest thing is the circulation part of it.
Terrific. I like that. Why? You're well done. I'm very proud of you. Why is that?
It's all about venous return. So hence why it's very important on left lateral to try and help the patient.
Terrific. So this is another form of obstructive shock, isn't it? Here, the obstruction is the fetus on the IVC. So VAFA's quite right. We roll them with a pillow under the right side. If we're worried about a spinal injury, we roll the whole bed. Just because I think there's a C-spine or I think there's a lumbar spine doesn't mean they should die of hypovolemic shock via the obstruction. We rotate the bed or the whole patient with a spinal board. Okay, so well done, VAFA. That was terrific. Okay, anything else there? How many people potentially here are we looking after with this trauma? Addison? 2. What's the best protection for the one inside? Galaxy?
I'm not sure What you mean by the question?
Well, the best protection for the one inside is the bit that's going to deliver the oxygen to the fetus. That's the mother. So this is a crude way of putting it, but for the purposes of trauma, the fetus is a parasite here that will be jettisoned to preserve the mother. So the best protection for that additional organ is resuscitating the mother.
Okay.
Okay, so this is two individuals with the best protection for the one inside, resuscitating the mother. And the first organ that the mother will jettison will be the fetus. So it also gives us an early warning system as well. Next slide. So the changes to anatomy. Okay, next slide. The first thing is the physical. 12 weeks, the fetus is becomes abdominal. From our purposes for trauma, happy days, we don't really worry about it. Under 12 weeks, you can fracture your pelvis. It's fairly robust. And if it is jettisoned as a miscarriage, there's nothing we can do then at 12 weeks anyway. So for trauma purposes, first trimester pregnancies are there and we have to think about them, but there's not a lot we can do about them, and neither are they usually a problem. 20 weeks at the umbilicus starts to be an issue. Once we get to 22 weeks, theoretically we can deliver at 22 weeks and you'll get a reasonable outcome. Certainly after 24, you're doing okay. After that, then it's an abdominal organism. So next slide. That's the physical things we can see. Okay, so first trimester, not a big issue. Thereafter is an issue the longer it develops, because the fundus is going to push everything else away. We're less likely to get bowel, we're less likely to get everything else, aren't we, if this is pushing everything away. So now we have to think of it as well as spleen, liver, and everything else. Next slide. We'll talk about isoimmunisation at the end. As we get closer to term, it is an abdominal organism. It has a high blood flow requirement, and it is easy to jettison and shear. Consequently now, this becomes the equivalent in our world of liver, spleen, and any other solid organ. We need to think of bleeding from the mother. We need to think of bleeding from the organ, which is the fetus, which is a parasite but has a different blood group, and therefore the problems there will be isoimmunisation of the mother, and the fluid that's there can get into the maternal circulation. So this becomes some difficulties. Our principles, however, are going to be exactly the same with some slightly different normals. Next slide. Anti-D is simple. We give it whenever we think there has been trauma and we do not know the blood group of the mother. It's of the father, sorry. It's pretty simple. We give it. 1 dose equals a 16-week fetus. That's the easy way to think about it. Okay, so we don't know the blood group of the father, we just give it. Next slide. Physiological changes. As you become closer to term, you don't breathe well. 20% of women at term are hypoxic. You can't cough, you can't breathe. It is because there is a big push up, you can't take a deep breath. It is one of the reasons we hate doing general anaesthetic for seizures, because the patient becomes hypoxic really quickly. The reason is you've got a big fetus pushing it up. So we need to take that into account and realise the mother has got less reserve. The mother's respiratory rate normally will be higher. For those of you who like numbers, the easy one is at 34 weeks gestation, everything is 34%. Your hematocrit goes down because you basically increase your circulating volume and dilute. All of your clotting factors go up by about a third. All of your parameters will be the same, but the actual numbers go up if we look at each group. You've just diluted it by the increase in circulating blood volume by about 34%. Your creatinine will go down because you've increased your circulating volume. Your minute ventilation goes up because of your progesterone, because of your increased fetus. Your CO2 goes down for the two reasons. One is your minute volume goes up, and secondly, it is a progesterone effect to make your minute volume go up as well. But your CO2 is 32 to 34 at 34 weeks. So my rule of thumb is at 34 weeks, the basic figure is everything changes by about 34% and you won't be far off. Interestingly, your cardiac output goes up by about, hang on, Hannah, I know this, hold your head here, about 34%. How about that? Because it does. All right, so at 34 weeks, pretty much that's what happens. You don't need to know the different normals, except to know they are different, okay? You just ring a unit if you're not used to it, and we'll tell you the normals that do it all the time, okay? Next slide. If we go back one though, can I point out that's why obstetricians or ladies can labour and lose what seems to be enormous amounts of blood volume. Fetus comes out, of course, you've now lost the parasite, and gee, they seemingly seem well. Well, of course they are, because they're designed to have about a third more blood volume than normal. Then when you lose the fetus and they have a hemorrhage, but you've lost the very thing that needed the third more blood volume, you can see why women can survive seemingly large blood volume losses, provided they deliver at the same time. Does that make sense? And that's the reason. Next slide. Oh, look at this. The same way we're going to do A, B, C, D. We're going to have to think about a few things. So aspiration risk is almost ubiquitous, simply because you've got a fetus there that's big. Secondly, you've got lungs that are already doing it tough. So thirdly, you're not going to want to eat much anyway. And one of the effects of progesterone is to decrease your lower esophageal sphincter tone. So aspiration is common. Ventilation, look, difficult ventilation is a terrible term. The answer is, if you know what you're doing, no, they're not hard to ventilate. Okay, they're basically a high PEEP, high oxygen life form. They're nothing different from saying this is someone with ascites, this is someone who has got a tense abdomen for any other reason, a packed abdomen, a Burns abdomen, pancreatitis abdomen, pick your cause abdomen. What they are is a tense compartment syndrome abdomen. This just happens to be with a fetus, and we have to ventilate it the same way. For our circulation, what we want to do is decrease hidden bleeding, and that means we roll you left side down so we get rid of the obstructive shock that is going to mask other things, aren't we? Then we have to think of hidden sources of bleeding, and in this one we have to think of abruptions and things, don't we? And lastly is eclampsia. Not uncommon. Is the cause of the accident a fit because of eclampsia and the accident? We're still going to do A, B, C, D, E, but is our coma score off because we're postictal? And the postictal, then we have to think, is this eclampsia, not head injury? In which case the treatment is delivery as well as the trauma, isn't it? Next slide. How do you evaluate and treat two patients? We're going to do the same things we do normally. Next slide. We're going to do our primary survey, resuscitate mum, because that's the best thing the fetus has. Then we're going to assess the fetus. We can do this with heart rate. We can do this with fetal movements. We're then going to go on and do the secondary survey of mother. Why is fetal assessment there? Because this is part of C, isn't it? In you and I, we have, don't we, the end organs are skin, urine output, mental state. Well, here we've got another end organ, we'll call it fetal assessment. So fetal assessment becomes part of C because it's an end organ we can use to assess the adequacy of the oxygen delivery to, instead of splanchnic circulation, here's something even further down across a semi-permeable membrane called a placenta, and that's the fetus. So it becomes our assessment as part of C here for that reason. And that's why it's before our secondary survey. Definitive care mum and fetus, yes. Rhesus negative we've talked about. Obstetric consult's important because we need two teams, and we all sometimes, to resuscitate mother, actually deliver the fetus. We do this more commonly in sepsis. We've done it a lot with COVID. We do it a lot now with flu A. We certainly do it with bad pneumonias that we're starting to use vasopressors on. We just want the obstetricians, if it's third trimester, we want the fetus out because it's one less issue we have to deal with, and that will get jettisoned if we're starting to use resuscitation drugs. So early obstetric consult's important for this group. Next slide. But the mother, same, displace the uterus, we've done, gee, we've done well. Look at that, we're going to do the same thing. The next slide will be the fetus. Resuscitate the mum. Heart rate is going to be our guide here. We have to always consider fetal injury. So what we have is a window to an extent here. One is ultrasound, but secondly, any vaginal bleeding is feto-maternal until we prove otherwise. Really important to think about that. So we need to think this isn't just maternal bleeding, is it feto-maternal bleeding? Uterine rupture is fairly obvious. Usually we have a catastrophic mum and a dead fetus and you can feel parts. That's not so bad. Uterine rupture, abruption is more common. You'll get pain in the abdomen out of proportion to what you find. You'll tend to get a tense abdomen. We worry about it for three reasons. One is the bleed, secondly is the fetus, and thirdly is the fact that we can get maternal problems lung-wise if we get amniotic fluid into lungs, etc. So we worry about it three ways. And then, of course, the rhesus. Next slide. So where to now? Next slide. To minimise the oxygen, and this is going to be your role in the wards, ladies and gentlemen. So we've done, haven't we, that in the ED. Look at this, we come back to what we talked about way back many weeks ago about your job in the ward to minimise the extraneous oxygen needs each of our vulnerable groups have. Straight back to our same algorithm. Next slide. So once the resuscitation's over, your journey in the ward is going to be to deal with that algorithm the same way we did before to optimise your patient's recovery. There's nothing fancy with trauma. It is exactly the same as every other sick patient. It just got there in generally an obvious or spectacular manner. But this is no different from your patient with pneumonia, with elective gut surgery, with their DVT, with their infarct, etc., etc. Next slide. So you're going to start with the algorithm. Next slide. We're going to look at your patient every day. Not now with hypovolemic shock, but remember, we're moving into our inflammatory phase, aren't we, of our patient. This is part of your response to any trauma. If you break your leg today, I will guarantee you will have a fever in 5 days. It's not infected, it's caused by your cytokine release. So now when you're looking at your patient, you're expecting a vasodilated state. But if it's worse than you would expect, you then have to consider, until you prove otherwise, this is sepsis. That is now your default position in our patient. Where is the dead tissue driving this response? The alternatives are going to be a DVT. The alternatives may be dead muscle in a compartment syndrome you've missed. But it's sepsis till we prove otherwise. So your patient day 4 or day 5, I would expect will be vasodilated. I will expect them to have warm limbs because that's how you heal. But I would not expect them to have urine output going off a little bit. I would not expect their base excess to be more than normal because that's meaning you're having to give them, aren't you, crystalloid fluid, which is acidemic in its own right, to keep them looking good. Well, something's not right here. So we have to go and find the sepsis until we prove otherwise. So can you see how that table we dealt with weeks and weeks and weeks ago becomes your friend now, going, oh yeah, this patient isn't quite right. They're not at 14 to 20. Their risk rate's a bit high. Now, I think this is more than just they've got a fractured femur and because their findings are out of proportion to just that. Does that make sense for you all? So this is your job in the ward to realise your normal now is a patient we expect will have a mild inflammatory state. So this will be our table we'll be using to say are they worse or not than what we expect. Next slide. And then when you get to unstable or unsure, you've come off that table. Now you can see decide and plan becomes, well, our table says this is what I expect on day 3 or day 4, fine. So I will give you an example. If somebody has a severe head injury today, I will expect them to have a fever for the next 18 months. That is part of how brains recover. So we need to factor that in, don't we, when we're looking at the patient and saying, is there anything else wrong? We need to realise that's their normal. Doesn't mean we won't look for sepsis, we won't look for things, but their normal is going to be a fever if they've had a severe head injury for the next 18 months or so. So we need to think about that for our normal. Next slide. No, I think next, there we are. So your chart review every day will be exactly what we talked about. The reason I'm reinforcing this for you is trying to get you to see that this becomes mundane. This becomes a day at work. This becomes boring. Your job is to make this boring because we've thought about the options. We know what we're expecting, which means now we've considered if it's not a rational approach. And you can see by using the approach I've outlined to you for any sick patient, this will work for trauma as well. Next slide. We go to Z. Next slide. Your management plan then is good enough to get you to come up with a treatment plan. It allows you to detail your measures. So we don't want delirium. That means I want this patient out in the veranda. The best thing to prevent delirium is make them absolutely exhausted during the day. I ventilate people on a veranda in my ICU in the sun. The reason for that is they get a sleep-wake cycle. In the ward, you want them down to physio, you want them flogged, you do not want them sitting in bed. Do you think it's better to give them Valium at night to sleep, or they're so exhausted because the physios flogged them all day, they sleep naturally? Which one do you think is going to do them better and prevent delirium? So as part of your management, that's what you're doing. Next slide. All becomes exactly this. Next slide. This same thing we talked about for the generic patient, nothing different. Nothing different. Feeds become vital. We want muscle mass. We want high protein feeds. Next slide. Nothing different. Next slide. Nothing different. That's your management plan. If you go through it every day rigorously, trauma is just another day at the office for a sick patient, for you as a resident in a ward. Next slide. Okay. The management plan will reflect the stability of the patient. Happy days. Next slide. Stable, easy. Formulate your plan, do your paperwork, fill out all of the various things for the Social Security. That's it. If they're not, which is the next slide, then this is what I expect every day you to think about. It doesn't mean at your level you will do it, but this is how I think about a trauma patient every day. And that's a neck of femur in an elderly person from a nursing home. That is a multi-trauma head injury. It doesn't matter. I go through A to Z every day. And this is a pretty much standard thing in a ward I would expect. Next slide. Unstable or unsure. Then we go through the same things we talked about for our sick patient. The investigations are, what do we need to do? And does the risk of doing them outweigh the benefit we get? The answer is yes. Then we don't do it. If the benefit is there, we do. In your case, you'll be talking and managing upwards to your registrar and consultant. Next slide. Okay, part 2, if we just go to the next slide, we're not going to be going any further than that. No, that was the one before. Keep going. Next time, analyse the trauma system. Next slide. Now what we're going to do next time is take you through how the system works from woe to go. And then after that, you and I are going to do a whole patient applying this system, woe to go. I know it went a little bit longer tonight, but we've now gotten our patient done organ by organ. Now we're going to look at the system, and then after that, we're going to apply the system to the patient. Everyone happy with that? I'm sorry it kept you just a bit longer, but it just seemed a nice place to finish for you.
Everybody happy?
And whoever it was who's freezing in Sydney,
Yeah.
Vinay, no, you're shivering, but you're okay. Well done.
She's coming to Brisbane for OSCE on Saturday.
Oh, are you? Oh, you're good. Oh, you'll be fine, Vinay. You'll be fine. If I can give you a tip for your OSCE, and I'm not doing them, I'm actually teaching a trauma course this weekend, the College of Surgeons. You guys are far harder on yourself for the OSCE than we as an examiners mark you. Okay? And it's the same when you come to your specialty exams. The candidates are far harder on themselves than the examiners. Isn't that right, Athel?
That's correct. Yeah.
Okay, so you guys will be fine. Okay?
Thanks.
We are not after rocket science, truly. We're after common sense, sensible answers. That's fine. And that goes for when you're a resident and when you all move on. If you think about specialising further, trust me, in exams, the candidate fails themselves, the examiner doesn't. It's so true. You'll be fine, Vinay.
Thank you.
All right. I'll see you in 2 weeks, and I expect you'll do well, Vinay.
Thank you.
That's if you survive the hypothermia from tonight, hey?
On my defense, we've just come back from Samoa, so.
Right. So is Athel, he tells me.
Yeah.
Some of us had to freeze here. All right. Thanks, guys. Thanks for putting up with the extra time, but I think it was worth it.
Thank
See you in
you.
2
you.
weeks.
Thank you.